Okay, guys, so what we're going to look at today is we're going to discuss the bracing, splinting, and orthotic devices for the ortho patient. I've written out a lot on this PowerPoint for you so that hopefully you don't have to take many notes. You can just kind of sit back, listen to some of the examples that I give for each of them and just try to understand the concepts a little bit more. A lot of these concepts and a lot of this information you've already had in other courses and other lectures. So some of that information I'm going to try to breeze through a little bit faster. But by all means, if you have any questions, please let me know. So we're going to look at kind of just some terminology first, look at the biomechanical principles of orthotic prescription, and then give you a little bit some more specific examples of when we would choose to use what and why. Okay, so if we look at the terminology, an orthosis is typically an orthopedic appliance used to correct deformity, prevent deformity, support certain structures, and just help with alignment. So the goal is really to improve the function of the movable parts of the body and try to protect things. The terms you'll hear, a brace is typically the same thing as an orthosis. A splint is really usually a temporary orthosis or temporary brace. And an orthotic is a lot of times the terminology that we're going to use when we're talking about something we put in the foot. But you may hear all of them used interchangeably and just kind of understand the difference between those. So as far as looking at our orthotic team, there's many different players in this. An orthotist is basically anybody that makes any kind of brace. They fabricate that out of whatever materials that they feel are appropriate for whatever the goals are for that patient. A pet orthotist is somebody that fabricates those more particularly for the foot and the ankle. We have physicians that can write referrals that can provide braces. For our particular patients, we have PTs, OTs that can actually make and fabricate different orthotic devices as well. ATCs are very critical as far as recommending particular types of brace for their athletes. We have social workers who a lot of times there's generally a pretty significant cost that comes along with these devices that we're prescribing for our patients. And so oftentimes it's helping them get the resources and able to purchase those, but also to help them manage when they're first starting to use this, making sure that they have all the available resources to do that. Psychologists are an interesting part, and a lot of times that goes along with some of the social stigma that goes along with when you see somebody that has a brace. So say it's a young kid that has scoliosis and now he has to wear this huge brace that goes from his sacrum to his cervical spine. So a lot of times the psychologists are somebody that we may refer to in order to help that particular patient integrate this into their lifestyle and help them deal with such a big change that comes with wearing something like that. So just make sure that we're not forgetting about them as part of our potential team with these patients. Okay, we're going to go over some biomechanical principles. Our goal basically with the brace or orthotic device is to apply some forces to the body. So the way that we're going to implement those forces is really based on what our goals are for that patient or for that particular device. With our force application, we're either going to resist or assist motion. We're going to transfer force from one side to the other, one body part to the other, and then also protect a body part. So if somebody just had surgery, we're going to put a brace on them to help protect them from going into extremes of range of motion, try to help protect whatever structures were fixed. If we look at transferring the force, if you think about somebody that has medial compartment OA of their knee to where their medial joint is pretty much shot, they have some good weight-bearing surface on the lateral aspect. What we can do is if this is my medial side, if they're typically wearing this down, I'm going to take a brace that pushes this way to open up that side. Now I can weight bear a little bit more on that lateral aspect. So that's going to help kind of transfer that force, but also protect that medial side a little bit more. We talk about resisting or assisting motion. We'll talk about the sawa brace, which is a shoulder abduction brace. So somebody that had a dislocation, we can put them in a brace that it protects them from going into this abduction external rotation. Get this a little bit more so you can see. So I want to protect them from going into this position. So we're going to have stresses and straps that hold me down into this position so that I can't get into that dangerous position. If you talk about something that assists motion, say somebody has a drop foot, they have some compartment syndrome on their anterior aspect of their calf. We can put something in their foot or in their shoe that attaches to the anterior aspect of their shin. So that helps assist in that dorsiflexion so they're not having to use the muscles as much. Okay, so those are the basic biomechanical principles that we're going to go with as far as how we choose what we choose. Some of the other things to keep in mind: the greater force in the greater body area covered is going to be the greater comfort. So if I have a brace that is just going where my watch is, okay, and something right here, that's going to be a lot more force than if I can cover this whole forearm and cover my whole hand and then support that and do the movement however I want to. So it's basically just dispersing that force over greater surface area is going to increase patient comfort with that. And that's a key thing for our braces, our splints, everything that we prescribe for our patients is if it's not comfortable, they're not going to wear it. We can either address 1 or 2 degrees of freedom around a joint. Okay, so we can't limit everything in all directions. And so we need to choose based on what that particular patient's condition is, what their goal is, which ones that I really want to focus on. So we can really only maximally address 2 degrees of freedom with this. Okay. So we talked about resisting motion. So we can control that excessive or that unwanted motion. So I talked about that shoulder instability. We can put them in the brace that limits abduction, external rotation. If somebody had an ACL tear, I can prevent that anterior shear of the tibia on the fibula, or on the femur, sorry. We can assist motion. So like I talked about, we can add something that helps with dorsiflexion. I can add something to the elbow that helps with elbow flexion. So it really just depends on what that goal is for that patient. One of the other things about transferring force too is we talk about a counterforce brace. We talked about this in ortho, and we talked about lateral epicondylitis or epicondylalgia, is to where I can put a brace that puts pressure right here, okay, on that particular patient. And so I'm taking the pressure theoretically off of the tendon and I'm putting it more through the muscle belly. So it just shifts that point of where the muscle is pulling to try to help protect that. And then as far as the protection of the body parts, we can do this as far as a range limiting brace like I talked about, going into that abduction and external rotation. This can be after a fracture. So there's a lot of different ways that we can protect our body parts with these. If we look at brace effectiveness, so we need to look at the application of the forces. Sorry, I'm going to keep adjusting this. Application of the forces, we look at pressure systems, the series of forces and counter forces. We'll talk about that a little bit more. And we have 2 really main types of force application. So it's either usually a 3-point or a 4-point application. And this just helps us achieve our goals depending on what we're looking at. So if we look here, I think you can see my cursor here. We have a 3-point system where we have 2 points pushing one way and 1 point pushing in the opposite direction. So we're basically creating a fulcrum to try to do some bending. So if we look here at the scoliosis brace, we have 2 points, and we're going to usually pick the peak point there, okay, at each part, to where this is pushing this way, this is pushing this way, and they're creating a counter force so that that middle portion can try to push that apex of the curve back over and try to maintain alignment as much as we can. Okay. If we look at here, this is one of the offloader braces that I was talking about. So we have 2 points pushing out and 1 point pushing medially into the joint. And so what that's going to do is that's going to shift the force going from the medial part of the joint over to the lateral aspect. So we can help reduce our patient's pain, help protect that medial compartment a little bit more that way. So usually a 3-point system is we're looking at offloading something. Or pushing, really trying to push something in one direction. And then the top and the bottom ones are really just creating a fulcrum. So the larger surface area that we have, or the larger the lever arm that we have for this, the more force we're going to be able to generate with that too. Okay, so that's just something to keep in mind there. If we look at a 4-point system, we're really looking at just controlling motion in general. So we're not really trying to pivot anything, and they're kind of alternated. So this is one of the post-op braces or the functional braces for like an ACL reconstruction. Okay, so we have this one at the top here. Okay, that's trying to prevent the femur from going in anterior direction. We have this one that's most inferiorly on the posterior aspect. Okay, so that keeps that from rotating posteriorly. And then we have these two in the middle. So what we're trying to do with this brace is we're trying to prevent that tibia from shearing anteriorly to try to protect that ACL. And so we have this point pointing back and this one pointing forward. So we're kind of creating a fulcrum to where it's going like this on the femur and where it's going like this on the tibia to try to prevent that anterior translation, if that makes sense. Okay. So one of the things we can do, we can just do some circumferential pressure also. So this is going to be getting pressure and force distribution from all over the place. So this is great for edema. This is going to be your TED hose that you can look at for reducing edema. A lot of times these will be used post-operatively to help prevent blood clots, just to help increase circulation. Okay. I talked about before, if it's not comfortable, they're not going to wear it. So looking at the area that we're covering that's actually touching the surface of the skin. So it's going to do a few things. It can give them a little bit more feedback, but the greater surface area that we have contact with between the brace and the skin, it's going to minimize those certain pressure points. So it's going to disperse that force quite a bit more. So it's going to be a lot more comfortable that way. And if we have those certain pressure points, so we have less touching the skin, there's going to be more pressure at those points. And so that's going to lead to skin breakdown. It can lead to pain. It can lead to callus, all this kind of stuff. One of the drawbacks of having more coverage is that it can be hot. So we're looking at these things that are using plastic, polyurethane, metal. And so after a prolonged period of time of wearing these particular devices, it can be very hot, it can be uncomfortable, they can smell, all that kind of fun. We want to try to keep a snug fit as much as possible because we want to prevent any kind of shearing forces. But if you imagine I have a knee brace that my leg goes like this, okay, it's going to probably slide down. So we need a snug fit as much as possible because we don't want that shearing force. So if I think about, that knee brace is sliding down, now all of a sudden where my axis of my knee was like right here, okay, and the axis of the brace started right there, okay. If that slides down, now my axis of rotation is a little bit lower. And so it's not going to do what it's supposed to do. It's going to create some abnormal forces that we don't want to happen. Okay, so we have to keep in mind when we're doing this, when we're getting a snug fit on the patient, that the more soft tissue they have, the more adipose tissue they have, it's a lot harder to get that snug fit. If they have some atrophy, you may not get that snug fit as well, but also if they've had an injury to where they currently have atrophy going on, that we might have to make some adjustments along the way. Okay. Levers is another thing to keep in mind. That's what I talked about with the 3 and the 4-point systems. If I have a longer lever arm, I don't have to generate as much force to do what I want to do. Okay, so the longer that we have, the less force that we have to go through that, which can lead to comfort for that patient. Okay, so we can look at materials also when we're talking about the makeup of this. Okay, so some of the things, we're going back to basic biomechanics, is we want something that's strong, but that's able to do what we want it to do. So it needs to be flexible enough to be comfortable for the patient as well. So if we have some stress that's going into this, it's going to lead to strain. The amount of stress required to cause strain or a change in that brace is what's considered stiffness. And if we have too much strain, then that can create a failure that can cause some serious issues with our braces and for our patients. So I'm just bringing this up to you guys again, the old stress strain curve. So just make sure that there's a certain point to where each material can go before it actually breaks and fails. So it's the same with bone, it's the same with your muscles, tendons, everything like that. But also if we talk about any of the materials that we're using to make up these particular braces. If we look at the properties, it's the same properties as when we talk about tissue. So elasticity is really the ability of that material to recover to its original dimensions after it's been deformed. Okay, so that's ideally what we want. So we try to limit the amount of deformation because if we have it stretch out a little bit too much, it's not going to be creating that stability. So we got to find a good balance between the materials and what our goal for wearing that brace is. We can look at plasticity, which is its ability to change shape without cracking. Okay, so that's bad news. Obviously, if it breaks, then we can't really do what we want with it. Malleability refers to plasticity under compression. Ductile is how much tension can it take. And then corrosion, you have to think about, especially anything that has metal on it. We don't want that to rust. We don't want that to break down. Also, if somebody's wearing this in an industrial setting where they're dealing with chemicals, if it's exposed to certain chemicals, we don't want that brace to break down just because of the environment that it's in. So those are all things that we have to think about. Fortunately for us, we use a lot of bracing companies that will come in and they will evaluate the patient one-on-one, fit them so that they get a custom fitted orthotic device, and then they'll take into mind, what that patient does, what their goals for function are. Okay. So talking about application of forces, again, we have to think about what these braces are going to do. They're going to either provide some compression, shear, tension, or bending and torsion. And it really just depends on what your goal is for that particular patient. So if we talk about compression, it's the amount that it's squeezing the material. So we want, with this picture right here, we do want some compression within there in order to provide more stable support for, limiting the fracture movement. If we look down here at this torsion, we're getting some bending, but we're getting some bending on these materials here as well. So this is a brace that would be designed for somebody that has maybe a flexion restriction or flexion contracture, of their elbow. So what this does is this would have a little dial or something to adjust with to where we're forcing that elbow into extension so that we get a prolonged stretch. So you'll see it do this. We can crank it up a little bit more, which gets a little bit more of a stretch, which gets a little bit more of a stretch. So we just have to keep in mind all the materials, what our goals are for the patient. The more perpendicular we go to the surface, the more force we're going to have, whether it's compression, whether it's bending. So if we look at this up here, if we're going closer to 90 degrees here and I'm trying to create a bending torque, that's going to have a lot more force than something that's right along this angle where it might be at 170 degrees as opposed to straight 90 degrees. Okay. When we're looking at shear forces, we want those forces to go directly across each other. Okay, so with these braces here, we want these forces to go directly parallel or perpendicular to each other. I guess it would be parallel, but crossing each other this way. So if I have one going this way and I have one going this way, I'm going to create some different forces. I'm going to create some bending forces as opposed to a straight shear, which is what my goal would be for that particular patient. Okay, so it's the application of those forces, and that's where we can get into evaluating our patients that are wearing these. I'm not somebody in the clinic that's going to make this brace for somebody with scoliosis, but I can certainly check the fit. So if I notice that somewhere in this region, they're getting a lot of skin breakdown, there's some erythema over their skin, there's some pain, bruising, anything like that, that's where I can take a look at it, see if anything looks off that I can fix. If not, that's where I'm calling the orthotist or the company that supplied this and having them take a look at it with the patient so that they can make adjustments on it. We talk about bracing. There's some other things to keep in mind. So we talk about the role of proprioception within this. It provides tactile and sensory input to the skin, so we get a lot more feedback that way. So that's one of the benefits of it. The other thing is that you'll have patients all the time ask you, I'm wearing this ankle brace. Should I try to go without it when I can or when I'm around the house because I feel like I'm going to be reliant on that. So that's kind of one of the drawbacks to it is that, yes, it provides great sensory feedback. You get the mechanoreceptors firing because you're getting some input to the joint with the movement, and it's understanding what that joint is supposed to do. You also get the surface tactile stimulation. So you get all this extra afferent activity going on that gives you extra feedback. Now, when I take that outside feedback away, how much is my internal system able to do? So that's where it's one of those, we have to kind of find that balance between how much do I wear it, how stable is that particular patient if they don't have it. So it's one of those things, a patient is starting to demonstrate that, they can do a single leg balance for 15, 20 seconds without that brace on a stable surface. I'm going to say, okay, maybe just wear this when you're going out and about, you're walking in the community, you're out in your yard. but maybe just around your house where it's a controlled environment, it's a flat surface. We're not looking at any slick surfaces, anything like that, then maybe try to go without it. So that's one of those things where it's patient education is important, but also evaluating your patient and understanding what their current abilities are before we make those recommendations. It facilitates dynamic control to prevent that injury. So if somebody has, a chronic ACL tear and they haven't had surgery, it can prevent further injury, because if I don't have any control of that and all of a sudden my tibia starts to slide when I'm doing normal activities, my knee may buckle, it may give out, and may cause further injury. So somebody that has, some dynamic instability at a particular joint, it's going to help facilitate that dynamic control, keep everything where it's supposed to be, so that they can function a little bit better. It can slow or control motion at the joint, which can be a good or a bad thing depending on what their goal is. So if they're just walking and they just need that nice control, that's perfect. If it's something that has a little bit more viscosity to it, to where it's going to bend a lot slower and they're going to do something like running, it's not going to match up, so that could lead to some issues. The slower that we move, the more feedback that they're going to get for that particular activity too. Okay, so just some things to keep in mind when we have our patients in these particular braces, understanding all that additional or that alteration of the feedback and how that's going to affect their function. There is some controversy in the literature regarding the role of proprioception in bracing. That's one of those things that I talked about where, I feel like I'm reliant on it. Okay, it does give you improved proprioception. Does that decrease after we take that off? So that's where you really have to be good as far as evaluating your patient with and without the brace, and see what they look better in, what they look safer in, and then understand that in regards to what they're getting back to as far as function. A lot of patients, when we talk about like ACL braces, so ACL braces, in the literature, if you go straight to the literature and look at it, there's really no difference between, do I wear a post-op functional brace after an ACL reconstruction when I go back to sport, or do I not? There's a lot of surgeons that will still just say, I don't care, I'm doing this to try to protect that patient. But a lot of times the patient also feels better knowing that I have this little extra device that's going to help me. So it's one of those things where, my patients ask, should I wear that? I'll say, let's talk to your doc, because I don't want to piss them off. But at the same time, the literature shows there's really no difference. As long as you have good neuromuscular control, you should be fine. But if it makes you feel better, that psychological component is so huge that we just say, go ahead and wear it if it's not impacting you. And then the other thing that they're looking at too is, if I get that proprioceptive feedback on my right knee that I just had ACL reconstruction on, does that change? Do I have any carryover into the other side? So there's some mixed literature on that side as well. It also looks at, if I'm wearing an ankle brace, does that have any effect up the chain as well too? Because some of those braces that we talk about, and when we talk about orthotic shoe inserts, it does have a slight effect up the chain. And so we're looking at, there's really not a definitive answer as far as, do I have improved proprioception now at my knee, at my hip, at my lumbar spine when I'm wearing an ankle brace? So it's still kind of up in the air, up for debate at this point. Some of the factors for prescription of the orthotic devices and braces are what's our patient goal? Okay, so do they need to get back to functioning? Do they need to use this brace in order to work, to go back to sport? So poor Tyler Eifert here, the man of many injuries, he's wearing this brace to help prevent that dislocation of his elbow again. Okay, do I need it to just walk, to just get around? Okay, so the biggest thing that goes into this is our physical exam for that particular patient. So we need to look at, what's that particular dysfunction? What are the demands of that particular patient? Do they have some neural component going on to it? In addition to it, how long do we think they need this for? Is it something that it's just temporary, they just had surgery, we just need to protect structures right away, and then eventually we can work them away from this? So it's one of those things that you have to look at that whole picture. What's the patient's goals? What is their dysfunction? How much do I feel this is going to contribute to improving their function and improving their safety? Where are they going to use it? Is it going to be at work? Is it just going to be at home? The financial aspect is huge. So some of these braces are super expensive. So just a post-operative knee brace is usually anywhere from $200 to $500, just depending on the brand and their insurance company. So we have to also keep that in mind when we're prescribing these, is that not everybody can afford these. And a lot of these devices, they're coming out of the patient's pocket. The psychosocial aspect is not one to take lightly either. Some of these braces, even just a simple post-op knee brace, it takes a lot to figure out how to put that thing on, how to adjust it, how to make sure it fits properly. So we have to keep in mind what their cognitive abilities are. Can they understand how to wear it, how to understand if it's not fitting properly, are they getting skin breakdown, what to do in that certain situation. That's a big key that we have to keep in mind with these patients. Have they had experience wearing something like this before? Okay. Did they have a good experience? Did it help them significantly? Did they have a terrible experience to where now I'm a little gun shy of actually putting something else on? Okay, so just keep that in mind. And then overall, we really want to look at, what do I think? How do I think this patient's going to be compliant? If I feel like they're not going to wear it, I'm not going to recommend something that's going to cost $300, $400, $500 if I think they're going to wear it one time and throw it away. Okay, so just try to be realistic with your patients. Do our patients a service by understanding all these components that go into it. Okay. So our orthotic goals, generally speaking, preventing impairments, reducing functional limitations, activity limitations, participation restrictions, minimizing disability, and just improving their overall function. Okay, so we got to keep this in mind when we're prescribing something as well. If I'm making an orthotic for somebody's shoe in the clinic, I'm still writing goals for that. So with our long-term goals, we want to just emphasize how using this particular brace is going to help them reduce their impairments, activity limitations, participation restrictions, and help them be more functional. Short-term goals, we want them to be observable, measurable, and have a time frame. So I want to say that, if I had prescribed this offloader brace, or if I'm fitting a patient for an offloader brace, it should have a pretty immediate impact on their pain levels at that medial compartment. Okay, so just make sure we're keeping that in mind too. And then our treatment planning, one of the biggest things is really educating our patients on how to put it on, how to take it off, what proper fit is supposed to be, what to expect if somebody has a super pronated foot, okay, to where now I'm adding an arch support, I'm adding a medial heel wedge to get them into a supinated position. Okay. I need to have them understand that their muscles are going to work a little bit differently. So we might not go just put this in your shoe and just be done. You might have to work your way into that, and that's really going to depend on each particular patient. Okay, but tell them, expect a little bit of some soreness. I want you to start off with maybe 2 hours a day to start. If you don't have any soreness, if it's just slight soreness, then maybe we can add an hour or two each day. If you get to the point where you're wearing it 6 hours and you're pretty sore afterwards, then we want to back down a little bit to where it was comfortable and then increase from there. Okay. We're going to talk a few slides about how we name certain things. Historically, these were named either by the designer who invented it, the place of the origin. So we had the Thomas ring by who designed it, the place of origin, the Milwaukee brace. We have the wrist drop splint describing what the impairment's for. Generally speaking, you're looking at the involved body part and the function that it is. Excuse me. So looking at just like a thoracolumbo-sacral orthosis, so TLSO. Okay, so we have these here. I'm just going to scroll through that. I think you can figure those out. It's basically foot orthosis, ankle foot. So we're just looking at, describing which body parts that it covers. If we look at the trunk and cervical orthoses, there's either corsets or belts. There's some rings that they can wear. They really lack rigid support. So they have, if you can see right here, they have a little bit of some rigid support within there. They're like metal inserts. Sometimes along the back, it can be a plastic insert that's molded to them to keep them in that position that we want them in. But the corsets and belt itself are not going to really provide any support. So these are where we're looking at some of these that are just molded particularly to that particular patient. We have either static or dynamic. So dynamic is kind of that extension assist splint that we talked about when we were talking about the hand. If you look at this picture here on the right, this is what I was talking about earlier, to where there's this little strap, this goes down and connects to the foot and assists with dorsiflexion. And then we have a static orthosis, which is something that just stays put. We have assistive, protective, and corrective. So assistive would be like these also. This would be a protective orthosis. Okay, and then we can have a corrective orthosis, which would be more of your scoliosis type braces. We also have rigid, semi-rigid, and soft braces. So this really just depends on the materials that it's used to construct the brace. So we'll talk about, kind of rigid, semi-rigid when we talk about the foot orthotics towards the end. But soft is, as you can imagine, it's soft. It's some foam that's pretty bendable and pliable. Semi-rigid means it gives some support, but it has some give to it. And rigid would be like a carbon fiber plate, which has no bend at all. So that's something that we'll put in the foot for somebody that has turf toe, where they don't like to go into that first toe extension. So it basically is a solid carbon fiber plate that goes along the whole bottom of the foot, and it doesn't allow them really any extension whatsoever. So it really depends on what your goal is for the patient, what the materials are that are used to construct it, to determine if it's rigid, semi-rigid, or soft. All right, so we have a lot of different materials that we can go through. We also want to look at, it has to look good. Besides being comfortable, it has to look good. If it looks ugly but it's very functional, the patient's still not going to wear it. So we need to look at, as far as the materials, how strong is it, how flexible is it, how well is it formed to that particular patient, how heavy or lightweight is it. If it's really super heavy, they're not going to want to wear it. They're going to fatigue with it. Then again, there's the key, is making sure that we look at, what does it look like? Does it look good? Okay. So we have some different plastics, we have some different metals. These all have different properties. So steel is going to be heavy, it's going to be strong. Aluminum and titanium are going to be lighter. Titanium is going to be a little bit stronger than aluminum. So it's really looking at what our goals are for that particular patient. How safe is it? How is it able to function? Okay, so there's a lot of different materials, so don't get bogged down in that. Okay, when we look at brace fit, that's going to be one of the keys to comfort. Okay? If we see an indentation somewhere, they're getting compression on some structures. Okay, so we just want to make sure we're watching for that. If we get any translation to where there's some give between the brace and their body, whatever body part it's on, it's going to slide, it's going to cause some shearing force, it can cause some skin breakdown too. Okay, and then we just don't want it to rotate or twist. So unfortunately, a lot of our limbs are, cylindrical, so we don't want to make sure that we want to make sure that it's not twisting on them. So if I have something for my wrist, okay, and the axis of movement is right here, and all of a sudden it twists here, and I try to go into flexion and extension, that's going to put a lot of force through some other joints that I don't want to. Okay, so like I said a little bit earlier too, the more soft tissue compliance that we have, okay, the more soft tissue, more adipose tissue, it's going to be harder to maintain that fit. Okay? You also have to think about, our limbs are not perfect cylinders. There's usually some kind of contour. So when we talk about the leg, the knee braces are almost the hardest things to get a proper fit on, because it just funnels down. Okay, so it's one of those things that after somebody gets fitted for these braces, they should be rechecked every visit just to make sure that it's still fitting properly, make sure they're not having any skin breakdown, making sure that orthotic device is actually doing what it's supposed to do. Okay. We have them by body region, so we can do anything on the skeleton. So on the axial skeleton, so we can have the cervical one. We can have any of your the scoliosis braces that we talked about, foundations. Upper extremity. This is the SAW brace that I was talking about. That's just the brand name essentially, but it's a shoulder stability brace. But you can see how this is going to prevent that abduction. There's some different straps that will prevent external rotation along with that. Okay, but these are nice because they can still use that, they can still function with that. We have some lower extremity braces that we'll talk about here shortly too. Okay, so I apologize if I'm talking really fast. It's really boring sitting in an office by myself and talking to a computer screen. So I apologize if I talk too fast. So if you're not getting anything, if you're not picking up on something, just please let me know. I'd be happy to talk with you a little bit more in person about this. So when we go into knee braces, so there's three main kinds of braces for the knee that you'll see. There's the prophylactic knee braces, which is basically something that I'm going to use to help prevent an injury. And this particular patient that I'm using it on is healthy. they don't have any injured body parts. So a lot of times where you'll see this is a lot of offensive linemen that play football. They put them in the braces that kind of look like this one here. Okay, and the reason for that is they get a lot of MCL, LCL type injuries to where somebody's striking their knee from the side. Okay, so it's really to provide that extra support in case something were to happen. There is some controversial literature on that as whether or not it actually reduces the injuries or not, or whether it creates actually more injuries because it already preloads the joint. But that's a whole other discussion. So in theory, a prophylactic knee brace is for a healthy individual, okay, to help prevent any potential injuries there. A functional knee brace, okay, is going to be that it can be that exact same brace here, but this may be used for somebody that had an ACL reconstruction. So it's for them to get back to function to protect those healing structures. And so really what determines the difference between a prophylactic or a functional knee brace is that person healthy or were they injured at one point. So that's kind of the variation, but it can still help provide that stability to those healing structures as they're functioning. The post-op or the rehab knee braces, they have a little bit more control. As you can see, this here is the post-op brace. It has a little bit more control. You can see it goes higher up on the thigh than this one over here. It goes lower down on the shin than this one over here. So it provides a little bit more control, and that provides a little bit more protection for when those structures are healing after a surgery or after an injury. So there's a couple different things that I put on here also. So this would be your functional your functional ACL type brace. This would be your post-op brace, which isn't necessarily just for an ACL. It can be a lot of different types of surgeries, so tibial plateau fractures, patella fractures. It's really just controlling that knee joint. This you'll see a lot. You'll see a lot of patients come in. You go to a church league softball game, you see about 75% of the teams wearing this. Okay? It's just a compression sleeve. It helps theoretically with the proprioception because they get that tactile feedback from the skin in addition to the joint. One of the things that this is actually good for is somebody that has OA. It basically provides compression. If they have swelling, it can provide compression, especially if we don't have that hole cut out right there. But it helps increase the temperature of the joint itself. So if somebody has OA, it's going to increase warmth, which is going to increase fluid production. So it can help actually lubricate the joint a little bit better and feel a little bit better for them. Okay, so I'm not a huge proponent of this, but I just tell my patients, if you tried it before and it feels like it helps, go for it. It's not hurting them. It costs $20 to $30. So it's one of those things that, you will see patients wear, you'll see them come in all the time. So just, understand what that's actually doing. This brace over here is called a lateral J brace. So this is kind of a protective one. It's a functional type of brace, but this is for somebody that has like a lateral patellofemoral compression syndrome. It's where that patella is coming out this way. Or if you imagine somebody that had dislocated their patella and it went out in a lateral direction. This has this little buttress, so it's a little raised piece of foam that's inside there. And then we put that right on the lateral border of the patella, right on the lateral border of the patella, and then it has these straps that we basically pull it across. So it's taking that patella and pushing it in a medial direction. So it can help prevent that dislocation force. It can also push that patella medially a little bit, which can take some of that force off of that lateral aspect away from the femur. So that's another brace that you'll see quite a bit with the knee. When we talk about ankle ones, these are, again, something that you'll see quite a bit of. The nice thing is when we're looking at the value of ankle braces, they're they've come a long way and they're very, very solid. And the nice things about these are they're much easier to use than they were even 10 years ago. They're much easier for the patient to get on, to fit, to strap all the straps. Usually there's color-coded or they're numbered to say which strap I pull and push on first. Comparing it to like taping the ankle works well. However, tape stretches out over time. So even in the course of a game or a practice, that tape can stretch out significantly. So by the end of the game or the practice, it's not really doing what you were taping them up to do. So over time, you don't have to pay for that tape over and over and over again, which if you use Leukotape, it's pretty expensive after a period of time. And also then comparing it to tape, you don't have some of the same irritations. So I don't have to use the cold spray or the like the sticky spray to help the tape stay on a little bit better. I don't have tape going right over the skin, so I don't have some of those irritations as well. Okay, so here's a couple different braces here that you'll see. So this is just a lace-up one. It just provides general stability. This one's kind of a combo. It's a lace-up brace with like a figure 8. So that can help provide a little bit more stability in a particular direction. So this a lot of times is used for somebody that had an inversion ankle sprain to protect that lateral aspect. And so what the figure 8 does is it basically pulls it out into eversion to help protect that even a little bit more. If you've played volleyball or ever watched any volleyball, you've probably seen half the team wearing these active ankle braces. So it's a little bit more rigid on the side, but it still allows that dorsiflexion and plantar flexion. Okay, whereas you can imagine the soft cloth on these, you know, it's got some rigidity to it, and so that's going to protect in all directions. So that's one of the challenges if you're trying to jump in this, you're trying to go into a deep squat to dig a ball, you know, that could limit your dorsiflexion and plantar flexion range of motion, whereas this allows a little bit more, but it provides that medial and lateral stability. Okay, so what we're going to talk about next is some walking boots or CAM boots. What CAM stands for is controlled ankle motion boot. So a lot of times you'll see these in patients for many different reasons. It can be somebody that just has a serious case of plantar fasciitis that basically limits their motion that they can go through. It can depend, you know, depending on how high it comes. So you can see this one here has minimal coverage up the lower leg. Okay, so that's not going to provide as much support as something that goes all the way up like this. You have some hinged ones that allow a little bit of motion, but they don't allow the medial and lateral motion. And you have some that can actually control the toe as well. Okay, so you'll see this post-operatively. It's something that's going to provide a lot of support. A lot of times it has like a pump up, like the old Reebok pumps that you guys are too young to know about. That gets a little bit more compression, so it really provides some good stability. So these are nice braces if we're really looking for stability for that patient. What we used to see is patients would wear these, and if you can look at and appreciate the depth of the heel on each side, I mean, it's a good inch and a half that they're off the ground. So trying to wear a regular shoe, a lot of times people that have altered gait patterns, they'd have hip problems, back problems, knee problems. And I wish I would have invented this, and if I did, you probably wouldn't see me right now. But they have recently come out with this little shoe lift that you can just strap over your other shoe, which helps even you out a little bit. So we're trying to normalize the gait pattern a little bit more that way, prevent any other issues that come along with wearing this, having that extra depth on your shoe, and it's going to have not alter your gait pattern nearly as much. If you can look at these, they all have a little bit of a rocker on the front around the forefoot there. So that helps normalize the gait a little bit. It's still not perfect. You're still going to see some alterations in their gait pattern. But again, these are just really nice braces to help provide some stability. I think that's all on that there. Okay. It's important when we're looking at these braces, when we're looking at anything, look at the evidence. Okay, so just make sure that we're not just saying, oh yeah, that looks good. I saw a commercial for it, you know, because there's some shoddy materials out there. There's some bad products out there. We want to make sure that we're doing our due diligence and researching what we're actually recommending to this. One of the things I highly recommend is establish some relationships with some vendors. Most times you don't have to call on anybody. Most of the times they will be calling you to try to sell you on their product. So that's where when you meet with them, you talk with them, you try to understand a couple different things. What's their product? Why is it better than the other products that are out there that are similar to it? Is there any literature on it, on the effectiveness of it, the safety of it, how long it takes for this to break down? What are your payment options? So you have to look at financial considerations with our patients. If there's a brace that's $1,000, I don't care how good it is. If there's a brace that's anywhere close to the effectiveness that costs $100, they're going to pay $100 every time. Okay, so just keep that in mind when we're talking with our patients, because these devices can get pretty expensive. Talk with your vendors. You know, a lot of times they have payment plans that they can put the patients on. A lot of times they have some assistance that they can give to the patients depending on how much that patient makes in a year. So just keep those things in mind when we're talking about it, but just don't, go and throw something out there just because you saw a commercial or somebody bought you a free lunch or something. Make sure we're doing right by our patients. One of the things, so kind of an example of that, there's a couple different braces out there for getting back motion. So somebody has some contractures. So let's say somebody had a knee surgery and they have this knee flexion contracture that you've been cranking on them, you've been doing joint moves, stretching, all this stuff, and they're just making either very slow progress or no progress. There's several different brands that make these static progressive type braces. And there's one product where I have to wear that 6 to 8 hours a day. There's another product where you have to wear it 3 times a day for 30 minutes. Okay, which would you choose? First off, we want to think patient compliance. So my patient's going to be more compliant if they have to wear it for 3 different sessions of 30 minutes as opposed to 6 to 8 hours a day. The literature on them is that this one is just effective as this one. So I think as far as looking at cost effectiveness, that would be the only thing to look at, but I would say patient compliance is going to be much stronger on the 3 times 30 minutes as opposed to 6 to 8 hours every day. Okay, so just keep that stuff in mind when we're trying to get these devices for our patients when we're recommending certain things. Okay, so the rest of this talk, which is about almost half the talk, is going to be on footwear and foot orthotics. It's going to be the most common thing that you actually work with, maybe even fabricate within the clinic. So I wanted to spend a little bit more time on this. We'll talk about some footwear prescription also, which is something that's simple and easy to get that you can help your patients quite a bit by just changing the shoe that they're going to buy. Excuse me, I am starting to lose my voice. I don't have my microphone going either, so just bear with me here. So when we talk about foot orthotics, just understand it's not just an arch support. It's a lot more than that. Our goal with these is to really identify the pathology in that particular foot. It could be for their knee, it could be for their hip. But we're really looking at each individual foot and trying to match their foot with the device that we're making. Okay? And our goal with this, if you can see in this first line here, is really maintaining the foot in or as close to neutral as possible position of that subtalar joint. So we'll talk about in ortho how we actually evaluate that. But just understand that our goal is really to get them into a neutral position or as close to neutral position as we can. Because that's going to help improve the biomechanics up the chain. Our goals with this is, to decrease any abnormal stress on tissue, decrease any inflammation in that area, improve blood flow, prevent any future injuries, improve alignment, and either to provide a rigid lever arm or to provide some shock absorption. So a lot of it's going to be based on the materials that we choose to do, but a lot of it's going to be individualized to that particular patient. It's much, much more common now than it was even 10, 15 years ago. So if you look here, the American, the foot people, the foot and ankle surgeons, American, I can't even think of what it is right now. But they did a survey of close to 1,000 runners. So 17% of this, and this wasn't that long ago either, 17% used custom orthotics and 23% used over-the-counter orthotics. So 40% of people that are running on a regular basis are using something in their shoe. Okay, and if you look at just the trend over the last several years, I feel like running has been much more hip to do at this time, even though hip's not probably the good word to use. But if you look at the Google search in 2005, there were 279,000 websites that you could get for foot orthotics, whereas now it's close to 2 million. So it's probably over 2 million because this was from about 2 years ago. Okay, so there's a lot out there. Patients are going to ask you about it all the time. You're going to see some patients that you're going to want to fit for these. Okay, so our goals really with foot providing a foot orthotic for our patients are really the 2 goals of our foot. So we want to get the heel flat on the ground. We want to get the forefoot flat on the ground. Okay, so if we look over here, we're looking at some of the deformities you're going to see. We're going to look at rear foot varus and rear foot valgus. Rear foot varus is much, much more common. Rear foot valgus really only occurs in the neurologic population for the most part. But if you see somebody that's uncompensated, like on this picture right here, Okay? That heel is not getting down onto the ground on that medial side. Okay, so I'm going to want to put something underneath that medial side so that I'm not taking all this force over my lateral aspect of the calcaneus. Okay, if it's compensated, that's how we normally work. Okay, in non-weight bearing, you should have a little bit of some varus like this. When we go into weight bearing, I should pronate a little bit to get that medial side down to the ground. Okay. If we look at forefoot varus, again, my heel now is on the ground, but if you can see kind of the toes right here, okay, that's uncompensated. My forefoot's not getting to the ground on the medial side. So that's where I might want to do some posting and put something under there to bring the ground up to their foot. Okay, and that's essentially the same thing we're going to do on this side. Okay. So we'll talk much more in depth in ortho as far as how we evaluate that, but just understand that our goal is really to bring the ground or bring the shoe up to them so that we're dispersing forces throughout the whole foot. Okay. If I'm like this, I'm having to use muscles a lot more. I'm taking a lot more force through the lateral aspect of my foot. With the forefoot uncompensated varus, I'm going to get a lot of force through that fifth ray. Okay, so that's where we can lead to stress fractures in that there. Just understand that when we're going through the normal gait cycle, we're going into supination first, and then we're going into pronation, and then we're going into supination as we push off. So depending on what they have going on, if it's the rear foot, if it's the midfoot, the forefoot, we might have to change our prescription based on what we want for our patients. So we want them to have a rigid foot when they land and when they push off, but we also want them to have a little bit of some cushion when they're going through the stance phase to try to adapt to those stresses that we're placing on it. So we have a couple different choices. We have some custom ones that you will just make completely. You can have off the shelf that they can go into any pharmacy or grocery store and buy. We have a hybrid, which is where you can kind of buy it off the shelf, but you can also heat it up to mold it to your body or to the foot. We also can just take whatever they have in their shoe already, and we can add what we call cookies, or they're just some little inserts or posts to where we just add a little something extra to what they already have. So it's not the entire insert that we're modifying, but it's just maybe one particular part. And I'll go over what some of those are here in a little bit. And then there's some shoe modifications that we can make also, so I'll talk about that too. So do we do custom? Do we do off the shelf? Okay, so some of the pros to the custom are that they tend to be more durable. The ones that I make in the clinic, usually it's about every 2 years that I have to remake one for somebody. So they're much more durable as far as the materials that we use. It matches their foot. It's very, very precise. I can make very, very tiny adjustments in a short period of time. It also depends custom. There's many different ways to do it. So the way I do it is we have, it's got basically 2/3 or 3/4 of the length of the insert is moldable. So I put it in an oven, I put them on this soft foam, and then I put their foot in a subtalar neutral position, and then I mold it directly to their foot. And then I can add any kind of posting or any other materials after the fact to try to make it match my goals for that patient as much as possible. So you can be very, very precise. There's some other ways you can do it. You can put their foot in a foam impression box, and you can send it off to a lab to where they'll make it and they'll send it back to you. There's some slipper casting to where you use plaster casting actually and put plaster on the bottom of their foot and just hold it in place with their foot in a neutral position. And then once that dries and hardens, then you send that off to a lab and then they'll make something there. Okay, so there's a lot of different options for custom. I really like the way that I do it just because I can make those adjustments. If they go and they wear it for 2-3 days, they come back on their next visit, they're like, I got this little tiny pressure point. I can grind that down. I can fix that. Some of the negatives to it is that the time can be an issue. With the system that I use, the Dr. Mangine uses a little bit different system, but we can have our orthotics made with that patient out the door. Whereas if I have to send it to a lab, it's going to be probably a 2-week turnaround. So they're not going to get them right away necessarily. They're a lot more expensive. Depending on which brand we use in our clinic, it's anywhere from $250 to $328 for a pair. Okay, some insurances will cover it, some won't. Some will cover it if they go to a podiatrist and the podiatrist makes it, but sometimes they don't recognize a physical therapist as being able to make that. So really, a lot of it depends on the insurance, but if they have to pay for it out of pocket, we usually charge about $250 for that. The materials for that actually cost anywhere from $60 to $100 for that. So, so there's some markup for our services, for our time in that, but the materials themselves are pretty expensive. I'll talk about the evidence here shortly. The other thing is that you have to do a follow-up. We have to make sure that they're fitting our patients. Okay, so we don't want any skin breakdown. We don't want to take stress off one area and put too much on another area. So we got to make sure that they're comfortable for our patients. We're not doing any more harm than good. If we look at the benefits of the off-the-shelf, is they can go in and purchase it and be out and in their shoe in 2 minutes, as long as it takes to go in the grocery store, buy them, and put them in their shoe. They're a lot more affordable. You can get them anywhere from $20 to you can spend $100 on them if you want. They tend to be pretty comfortable. They tend to have a little bit more cushion, but that goes against that durability. So a lot of times that's one of the cons, is that they're not as durable. They're not using as solid materials, and so they can break down a little bit quicker. So as opposed to 2 years, it might be 6 months that they have to purchase new ones. So if you think, if I buy an orthotic that's $30, $40 and I have to replace it every 6 months, so that's 2 years, that could be $150, $200. That's almost the same cost as a custom one that's fit directly to you. So it's really kind of weighing those benefits. A lot of times we'll use, if you look down here, kind of a predictor of success. If it helps with that off-the-shelf one, then chances are that a custom one's going to help also. So it can be kind of a trial thing. If you don't want to spend the money up front, if you don't know if you're going to get any benefit out of it, why not try an off-the-shelf one first, and then we can talk about making some in a few months. The comfort can be an issue too, so it can be a pro and a con. They tend to have good cushion, but again, they're not going to fit every single foot the exact same way, especially if we have somebody that has a size 14, 15 shoe. Good luck finding an off-the-shelf orthotic. So those are some of the things that we can look at. There are some, changes in technology where, the Dr. Scholl's thing, you can stand on there and it'll evaluate your foot type and give you the best one for it. So the off-the-shelf ones have come really a long way. So a lot of times, if it's something that the patient's foot is not too wild and crazy, not too pronated, they don't have, too much going on, then a lot of times I'll say, try an off-the-shelf one first, and then we can talk about a custom one. If it's something that's kind of a wacky foot, where I feel like I need to do some different posting at a couple different points, that's where I'll recommend the custom. But like I said, that off-the-shelf has improved pretty significantly over the last even 5 years or so. There's some newer materials so that they can give more support to somebody that's bigger, that needs more support, that has more of a pronated foot. According to the literature, there's really not much of a difference. So these are 3 different studies, kind of the results of 3 different studies. So there's a lot of literature out there that says custom versus off-the-shelf, you pretty much get the same benefit. And I think a lot of it has to do with the type of foot. So most people are, a neutral to a slightly pronated foot. And so it depends on the population that you have to look at for those particular studies. So most of the off-the-shelf will fit most people. But again, I, err on the side of, if they got something wacky going on, I'm probably going to make something for them. There are some literature that says that the custom orthotics are better at improving plantar fasciitis syndrome, and some that show that they have better pronation control with custom. Again, that's because we can build that up directly to match their foot. So I can post on the rear foot, I can post on the forefoot, I can bring their arch up to their foot, as opposed to relying on something off the shelf that may not give them as much support as they need. We look at it again, we're not always looking at it for just the foot conditions, and we'll talk about these a little bit more in ortho. But there's been a lot as far as what can we do with orthotics to help with knee valgus. So knee valgus leads to a multitude of issues at the knee, at the lower leg, at the foot, at the hip. So controlling that, there's this clinical commentary that you can look for. Basically, they've done studies to where they have somebody that has excess knee valgus, and they'll put these orthotics into their shoe, and then they'll do some tests again. So it might be a step down test. It might be watching them walk. Looking at an X-ray, MRI, some of the functional radiologic screens that they can do, they're not noticing any significant changes in how much pronation, how much valgus, whatever it is that they're looking at. But what they have seen is that the clinical outcomes of the patient are significantly improved. So you might not see, visually that you're getting a significant change, but there might be just enough, and it could be proprioceptive related. We're not really sure. But there has been shown to be some benefit of doing some orthotics to help control the valgus at the knee. And so we'll talk again about that a little bit more, but just understand that, our orthotic foot control is not just looking at the foot. We can look up the chain also. These are some of the little inserts or posts that we can do. So this picture here on the left is a medial heel wedge. Okay, so that's for that uncompensated rear foot varus. It's where that foot is not pronating, and that's not going to get that heel on the ground. So I just build something up to where now I'm supporting throughout the entire calcaneus, and they're not just weight bearing on this lateral aspect. We talked about metatarsal pads, I believe, at some point. I think it might have been in foundations, but this is a metatarsal pad. So this is something that you would use to either take stress off of one particular metatarsal head. Say they have a plantar flexed first ray, I can move this over to where now I'm supporting that there. But I could also bring it over this way if that one's plantar flexed, and I can build up underneath the other ones. So it really depends on what's your goal, what's comfortable for that patient. This also, if we put this between the metatarsal heads, it's going to take two metatarsal heads. If I put it there, it's going to separate those out. So if we have somebody that has like a Morton's neuroma, which is basically an enlargement of one of the nerves, the digital nerves in the foot, I can take stress off of that by splaying that out a little bit. Okay. The metatarsal bars, if you can see on this picture here, let me enlarge this a little bit. Okay. Nope. Let me get rid of this guy. You can see we put this just proximal to the metatarsal head. So if somebody has metatarsalgia, they have pain over their metatarsal heads. What I'm doing is basically putting this just proximal to that. So now that they're getting their weight bearing through the distal shaft of their metatarsals and taking some of the stress off of the metatarsal heads themselves. Okay, so that can just help reduce the pain for that patient, improve their function. Now we're going to get into the fun world of footwear. There are a ton of options. Okay? There's a ton of brands. There's some brands that I have biases towards than others. So really just be a good consumer for yourself, but also for your patients. So when we look at footwear, there's a lot more that goes into it than just what it looks like. Okay, so we're going to talk about the last shape. We're going to talk about the structure of the inside of the last, the outsole. So the outsole is basically the part that's hitting the ground on this picture here. Okay, we have the upper, which is right here on the back portion. Okay, and that helps control the heel. We have the midsole, which is basically what material makes up the majority of that cushioning between the insole, where your foot is touching, and where the shoe is touching the ground. So depending on the type of material, you're going to get either more stability or more cushion. So it really depends on your goal for that particular patient, which one we should choose. Okay, so I'll break this down a little bit more. So we have the uppers a little bit, which is right here. We also want to look at the toe box. How wide is it? How wide is the patient's foot? We can look at the vamp or the lacing options that we have up through here. So there's different ways of tying the laces. I'm not expecting you guys to understand that at this point. You have the tongue, obviously. There are some things that, the tongue, to keep it from sliding around in there, that have like a little flexible piece of elastic that helps keep it in place a little bit better. We have the heel counter, which is right here. And then we have the insole. And ideally, we want to find shoes that have insoles. Unfortunately, a lot of running shoes, if it's a good brand, usually you'll be able to take the insole out. If it's not as good of a brand, a lot of times it's kind of glued down a few pieces, or with a few pieces of glue. But the nice thing is you can usually rip those out and just peel off whatever comes off of there. But ideally, I ask my patients, if I'm recommending footwear, just in case there's a potential that we do some kind of orthotic, whether it's custom or off the shelf, to find one where that insole can come out. So most of your good running shoes like Mizuno, Asics, Saucony's, Brooks, those all tend to have the removable ones. So just something to keep in mind when we're prescribing a particular type of shoe. So if we look at a little bit more into the shape of it, our goal, we want to match the shape of the shoe with the foot, okay, and what our goals are. So we're looking at the last, which I have a little bit better picture here. Okay, this is the last here. Okay, so it's basically the shape of the shoe. Okay, so you have a straight last, which is more like this, and you have a curved last, which you can appreciate kind of goes a little bit more like this. So that straight last is a little bit more motion controlled, whereas if we have that curved last like this, it allows a little bit more movement on the medial aspect because there's less shoe over here, there's less shoe hitting the ground here. So that can add to a little bit more cushion or flexibility. So if I have that hypersupinated foot, I'm going to look at probably a curved last, where if I have an overpronated foot, I'm going to try to find something that's a little bit straighter. But again, I got to match the patient's foot. These tend to be a little bit lighter as far as the curved last because we're looking for that flexibility, we're looking for that cushion. Whereas the heavier, we're trying to create a little bit more stability with that straight last, so they tend to be a little bit heavier, a little bit denser materials. Okay, so this here shows you a little bit better what the straight last looks like as compared to the curved last. You can see it kind of going like this here. We're looking at the inside, so if you can take the insole out, that's another reason why I recommend those, is you can actually look at the bottom or at the top of the insole of your shoe. So if you take the insole out and you look at it, you can see what the board construction is. So we have a board, which is where you see no stitching whatsoever. Okay, that's going to give you the most support. It's going to be for the controlled foot. So that's where we're going to try to recommend these with somebody that has an overpronated foot. The slip is where you'll see some stitching right down the middle of it. And what that just shows us is that the materials are a little bit softer, so it allows a little bit more flexibility. And that's throughout the foot. And then you can have the combo to where maybe my rear foot is actually pretty stable, or maybe it needs a little bit more cushion here, okay? To whereas I need a little bit more flexibility in the forefoot. So you can see, and it can be reversed also. So I can have, a solid up here and I can have stitched back here, but this is usually what you're going to see to where it's solid in the rear foot and it's stitched in the forefoot. Okay. When we look at the midsole down on this bottom picture here, I think I'll talk about this here shortly. Here we go. Look at the color usually. So, they've come a little bit more as far as not making it as noticeable, but if we're looking at the midsole, so we're looking at a neutral shoe, which is pretty much one solid piece of construction all the way through here. Okay. So, and you can usually pick up the shoe and push on it. And we're looking at the medial side of the foot for the most part, to where it's the same material here as it is here. So all the way around on this midsole, it's the same density of material. Okay. If we look at more of a stability shoe, okay, you're going to see a little different color, and it could be right through the arch, it could be in the heel a little bit. Okay, but you're looking at, if I push here, this is softer than if I push here where this dark gray is. So most of the shoes you can see a difference. Sometimes now what they've done is try not to make it as noticeable, so it's all one color, but they might be like spotted or some speckles or something like that in here so that you can tell it's a different density than the rest of the shoe. Okay, so this is going to be softer, this is going to be a little more firm, which is going to help create a little bit more stability. Okay, so this we can use for a normal foot as long as that is more through the arch area. So that's just going to help support that a little bit more. Where you get the dual density is where it usually covers the whole thing. Or if you look at what's considered a motion control shoe, it's controlling from the rear foot all the way through the midfoot. Okay, so you might see that now this entire area, kind of like this picture here, is a completely different density. So it's a little bit solid. It's really for that excessive pronator to try to really control that motion of the foot as much as possible. And when we look at the materials, so there's dual density is going to be the firmest. Okay, so that's going to be the really dark. When you pick up that shoe and you try to squeeze on that medial aspect of it, there's not going to be much give at all. The EVA midsole is still stronger than this here. Okay, so that there is going to be the polyurethane typically. Okay, this is going to be more of the EVA, so it's got some cushion, but it's still pretty solid compared to the polyurethane. And then we have the dual density EVA. which is going to be even a little bit more solid. So really what we need to look at is what's the patient going back to, what's their goal for, or to get back to, what's their foot like. The other thing we have to keep in mind is what's their body weight. If I have somebody that's heavier, I'm going to probably recommend something that has more of a dual density EVA than an EVA. Okay, even if they have a neutral foot, I might look at recommending an EVA as compared to a polyurethane. Okay, so our shoes can take a lot of pounding, and so we need to make sure that we're adjusting the materials based on what that patient's body type is, along with what their foot is. But just if you look down here, just kind of a little synopsis, is that just changing the midsole can significantly impact how the muscles are firing. So we just got to keep that in mind. So it's not just go buy a shoe because it looks good. So we got to really try to educate our patients on proper fit, proper materials, and how to do that. So it's nice, like I've developed, which I don't have on me, it's on one of my work computers in the clinic, but something that it's a little handout that basically tells them what to look for based on their foot type. When we look at the heel counter, that's going to be one of the biggest things, the easiest ways to say you need a new shoe or not. So if you take this shoe, so this is the heel counter here, it provides that rear foot stability. If you take it and push in it like this, and it just gives, they've worn their shoe out too much. That's why you always recommend the patients, untie your shoes before you put them on and take them off. Because if you leave it tied and you just keep slipping it in, you're just going to break that down a little bit faster. Okay, but it's plastic that's inside there, so if you get to the point where you're pushing on it and it just gives a lot, you know that it's pretty worn down, so it's probably not doing them any good. You used to be able to actually look at the outsole of the shoe and look at the bottom of it and look for like wear patterns, but they've made the material so strong and durable now that unless somebody's had it for way too long, it's really hard to see. You might not see it till they have 200 or 300 miles in that particular shoe. To where I can say, okay, you're wearing down on this medial aspect, or you're wearing down on this lateral aspect, either your forefoot or your rear foot. So it used to be the materials weren't as good, they broke down a little faster, which made it a lot easier for us to look at somebody's shoe, see how they walk, see how they run, based on where their wearing pattern is. But they've made the materials so good and so durable now that a lot of times you have to look at how much the outsole and the midsole compress, how much that heel counter compresses. So those are some of the things that, just to kind of give you some tips to look for as far as, is this shoe too old? Is this really actually supporting this patient anymore? Okay. It's usually, so the outsole, if we look at that, it's either blown rubber or carbon rubber. They're lightweight, they're flexible, so they allow some flexibility. There's going to be some of these grooves in there along the way that allow for that motion at the forefoot. And we just really want to match it to their activity. So, if somebody is running, we want something that's a little bit more durable as opposed to just walking. So you'll see a little bit of a variation in running shoes and walking shoes as far as the material construction, but just try to have them find something that is going to match their particular activity. When we look at the insoles, again, we should be removable. Okay? That way we can take a look at it, we can make adjustments as necessary, we can look at what the last construction is like. There's some that can be shock absorbing, there's some that have gel in them now, so there's all kinds of different things. So there's memory foam ones. It's really looking at what is my goal for that particular patient. So ideally with this, if it's not a custom insert that we're putting in there, it should really just limit sliding, limit gliding, and it should provide a little cushion, a little bit of support for them. Okay. So our goals with footwear intervention, again, like I said, it's really matching what that patient is going back to, matching their body type, their body weight, matching their foot type as much as possible. Okay, so we want to look at, it can go anywhere from complete motion control, so something like this, to where if you look at the bottom of this shoe, this is a motion control shoe. If we saw the medial side, you'd probably see a different color of the midsole all throughout this area. But if you look here, there is a lot of shoe right there. So that whole medial side is on the ground, so they're going to get a lot of support throughout their entire foot. So where if you have something that's more of a shock absorption, you're going to see it minimalist kind of through this area here. Okay, so where this is more shock absorption, it's lightweight, it's softer, Okay? This is why I don't like the Nikes, mostly because of the insole on those. So just to kind of sum this up, we're looking at shoe prescription. Okay, so this is kind of, these next few slides are kind of key points as far as understanding what I need to know, what you guys need to know for when you go out in the clinic as far as shoe prescription. So if you have that flexible foot, that overpronating type foot, we're going to get a straighter last with the board construction. Okay, we're looking at EVA, or we're looking at the dual density, and we might have to make changes based on their body weight. So if they're a heavier person, we might want to go up a little bit. Okay. We can use the polyurethane midsole if their body weight is not as high. Okay, but we really want to look probably more at the EVA than anything. Some medial midsole stabilizing device. So there's a lot of things that can kind of go into it here. You can see that in this picture here, there's a little something extra put in there, and it really just limits the amount that they're allowed to pronate there. Okay, so there's some other things that can go into it too. Reinforced heel counters, we just want to make sure it's nice and solid to where it's not going to let them move a whole lot into pronation or supination. Okay, so we're just trying to control them there. And then we want to look at that removable insole. So you can see that removable insole is for all the different body or foot types. So if we're looking at the rigid foot, the supinatory foot, okay, that's where we want the curved last. That's going to allow them to pronate a little bit more. The stitched slip last, okay, where we have that that stitch going all the way down the middle. That's going to be a little bit softer on one side versus the other. It's going to allow them to pronate a little bit more. Okay, this is where we're looking at EVA, but more likely we're going to look at polyurethane to allow a little bit more cushion. Okay. If we have a higher body weight, you might want to think about going up to an EVA with that. This is a funny word. Okay. Single density midsole, avoiding stabilizing additions. So we don't want, so whatever you choose, we don't want something that has multiple parts there. Because if we have different densities throughout here, those additional densities are going to limit the amount of pronation that they can do. Okay. Where was I? Okay, again, midsole cushioning. We want more cushion with the supinatory foot as much as possible, so that they can pronate, they can get some shock absorption, they can get their foot to the ground. Again, the firm heel counter and the removable insole. In the neutral, there's kind of a mix in between the straight last and the curved last. Okay, so we're just looking at, not something significant at either end of the spectrum. So we can have either a combination, or we can have a board construction. With the EVA or the polyurethane, it can be either way. A lot of times it really depends on body weight. Again, we don't necessarily need any stabilizing additions. I know this picture showed that we can have a little something for the normal foot, but I would say shy away from that. You would look for a normal foot, a neutral foot, looking at this neutral shoe where it's the same density all the way through. Okay? Whether it's polyurethane or the EVA, it really depends on their body weight also. Okay? And finally, so general recommendations, how often should I get new ones? Okay, if you're pushing on the heel counter and it's collapsing, get new shoes. Okay, if it's somebody that just uses their shoes just for running or just for walking, the typical recommendation is 300 to 500 miles, somewhere in there. A lot of it, again, depends on the intensity that they're doing. So somebody that's just walking and just going at a brisk pace or at a leisurely pace, we can probably get 500 miles out of it. Somebody that's running 5, 6, 7, 10, 12 miles at a time at a pretty good pace, we're probably looking at 300 miles. Okay? Make sure that when they're going, so I would recommend them to, an actual shoe store as opposed to like a Dick's Sporting Goods or something, because unfortunately some of those places, they have some good people that know what they're talking about as far as shoe prescription, but some are just going to say, this is what everybody's buying, this is what looks good. Okay, so I recommend some of the particular shoe stores, so the Good Feet store, Bob Ronkers, the Queen City Running Club, the Good Feet store, Fleet Feet. So there's a bunch out there, and they have trained people that know all these ins and outs of these different types of shoes. The nice thing is that, when you're going to try them on, if you go to like a running store, usually they'll let you put them on and actually go run with them on. Okay, so recommend trying it on both feet because some people have some slight variations from one side to the other. So it might feel great on my right foot, but it might feel awful on my left. So I want to make sure that it's fitting properly on both sides. And then also just think about your cost versus your function. Okay, so you can spend $300 on a new pair of shoes that might not do you any good, or you can spend $50 on a decent pair of shoes that'll work great for your foot. Okay, so just understand those general recommendations. I would say the key points on these are really to understand, on the different foot types, what kind of last, what kind of board construction that we have for each of these. So again, let me know if you guys have any questions with anything. There are in HSC4 in the closet in the back of the room, there's a couple bins of some of these types of things. So some of the different braces and boots and stuff like that. So if you haven't actually seen them, many of you guys have probably seen them when you're out on your mini clinicals. Go ahead and take a look and just let me know again if you have any questions.